Dr. Newsom-Davis. He's a medical oncologist at the Chelsea and Westminster Hospital, and he set up and leads the Chelsea and Westminster Acute Oncology Unit, and also chairs the London Cancer Alliance Acute Oncology Group. Dr. Newsom-Davis has an active clinical trials portfolio for both the National Cancer Research Network and commercial lung cancer studies. He is also divisional lead for research at Chelsea and Westminster, and is also a member of the National Cancer Research Institute's Lung Cancer Clinical Study Group. He's also led a number of acute oncology research projects, including the development of an acute oncology e-learning course, and an app. So welcome, Doctor.
Thank you. It's a bit out of date, actually. I should also say.
Is it?
Yeah, I should say that I'm also the vice chair of BTOG, which is the British Thoracic Oncology Group, which is something I'm very proud of, which is essentially we hope is a kind of forum for healthcare professionals looking after patients with lung cancer. And we have, of course, patient advocates in that group. And that's something I'm really, really proud about. I think that's the past few years.
Apologies for missing that off.
No, it's my fault. It's out of date bio. Apologies.
No. But I also knew it, so I should have realised it wasn't on there. So if we get started, if that's all right. So as you know, a number of people have sent me questions, which are sent over to you to have a quick review. But I don't think there's anything in there that's going to be too much of a shock for you. But if I start with the first question. So alectinib and brigatinib have been approved for first-line use. How do you decide which to use?
Yeah, I think this is probably the thing we all get asked the most about. And I think the first thing to say is there isn't a right or wrong answer, broadly speaking. There isn't some great drug everyone should be on, or some terrible disaster if you're on something else. I think broadly speaking, we can say a couple of things. We can say that alectinib is what we used to do. So I'll start again. Crizotinib is what we used to do as a first-line treatment for ALK-translocated lung cancer, but that's kind of not so much the case anymore. And we have now moved on to the next generation drugs. So I think if any of you have, or your relatives or your friends have been recommended to have either brigatinib or alectinib or lorlatinib, I think you're all in a good place, because all those are very reasonable treatments. If you happen still to be on crizotinib, because that's what you started on because it was a while ago, before the other drugs became licensed, that's also great because it's still a very good drug. It's just been somewhat superseded, and the same would also go for a drug called ceritinib. How do you choose between them? Well, the answer is ALK is completely unique. And of course, you guys know that much more than I do. But it's completely unique because it's the one situation where we would expect to have a series of treatments. We hope over years, and that's a reasonable thing to expect. And that's just amazing. It really is an amazing thing to be able to say. So it's really unique because when we're choosing our treatments in oncology generally, what the doctor is trying to do is to say, I've only got one shot at this. So I've got to get my very, very best drug first, the one which is most likely to work, and most likely to work as long as possible. I'm going to use that one first, and then we'll worry about things later on. And you can see why that's kind of logical. But in ALK, we would expect to have multiple lines of treatment. So maybe the desire to absolutely get the most effective drug as the very first thing you give isn't so important anymore, because you're going to be expecting to give lots of different drugs, hopefully 2, 3, maybe 4, who knows, over a long period of time. So I think that's the first thing to say, which is so long as you're on the next generation drug in someone who's starting recently, you're in a good situation. We should look at effectiveness. But actually, if you look at the data, they're all very similar in terms of what they're achieving. They're all very good. All the trials are slightly different. And I don't think at the moment we can say whether one is better than the other because no one's ever directly compared those particular drugs. So then we move on to things like side effects, quality of life. How easy is it to take? How many tablets you have to take? How often in a day do you have to take it? And those come into it as well. So I don't honestly say, and this is a real politician's answer, I don't honestly believe there is a, you must be on this, you must be on that. My personal take, for what it's worth, but you ask someone else to get a different opinion, is that alectinib and brigatinib would be my first choices.
Okay.
Either. And I think that keeping lorlatinib in reserve for later is probably what I would do, because that's really a drug which works well in that relapse setting. And that's my personal take.
I don't think so.
Okay.
No.
Can I ask everyone to mute, please? There's some background noise going on. Thank you. So if lorlatinib gets approved for first-line use, which obviously they are applying for, can you do you think there's any circumstances in which you would use it first line?
Yeah, it's a good question. So first thing to say, it is approved for first-line use. It's just not funded by NICE at the moment. So it's licensed in the first-line use. That's a really important thing to say, because there is a difference between what has been proven and what's been licensed. And that means that the drug company's gone through the process to say, can we have permission to give this drug in this situation? That has been given. And the other is who's going to pay for it, which is obviously very important. And that's what we're waiting for NICE and Cancer Drugs Fund to say. So drug companies really want to have their agent as the first-line drug. And the reason for that is more people get that drug. And there's prestige about having your drug as the first-line one. But what we've all been saying as oncologists for a while to the industry community is saying, I don't think we should be worrying about this too much. We should actually be saying, what is the best drug for the best situation? And I think the feeling with lorlatinib is there's a couple of reasons why we kind of want to keep it in reserve. Number one, it's the one that's got the most evidence after other drugs have been used. And the reason for that is because it was later being developed. So it's later been developed, it's been tested usually as a second or third TKI or targeted therapy that people have taken. The way it works is it's particularly effective against some of the types of ALK lung cancer which develop when someone's become resistant to, example, alectinib or brigatinib. So you really want to have something up your sleeve for later. The other thing about lorlatinib is very, very good at getting into the brain. And you kind of want that, because if actually, for example, someone's cancer is really well controlled from the neck downwards, but in the brain we're really struggling, you want to be able to reach for a drug where it really gets into the brain. So for that reason, I see lorlatinib as a great drug to go to as a second or third line option. I don't see that as a detrimental thing or a bad thing, although I think from a point of view of a commercial benefit, I suspect it's not quite what drug company wants. So no, I don't think I would be reaching for it as a first line drug. And even if it becomes funded by NICE, I'm thinking long term. I want to be thinking years. And I want to have in my head when I start a drug, a reasonably clear idea of what I'm going to do over the subsequent months and years that come.
Brilliant. Thank you very much indeed. So I want to go back to alectinib now, because there's some questions on that, if you don't mind. So someone's written in and said, I'm on a reduced dose of alectinib because of a reaction, a rash. Would it be worth trying a reduction in dose in that situation rather than a switch?
So there are a couple of questions about dosage. I think they're really, in fact, they're all brilliant questions and all really interesting. So dose is very interesting in the way that we do things. So cancer medicines are almost unique in this respect. The dose that is recommended as a starting dose is the highest dose that can be tolerated. And that's might sound a bit obvious, but it's actually not like most medicines you take. When you take paracetamol, you're taking the lowest dose that works. That's what 1 gram 4 times a day is. It's the lowest dose that works. Whereas cancer drugs, we give the highest dose you can tolerate. The technical term is maximum tolerated dose, or the MTD. And cancer medicine is a bit unique that way, because that's the way they've been developed. You're trying to get maximal effectiveness. So when someone starts on a dose, you're starting at that because that's kind of the optimal dose you can do. You often have to reduce the dose of that because it isn't tolerated. But so long as you're reducing the dose for good reasons, for side effects, that's the dose that is right for you. And it's a pretty crude process. You might imagine there may be someone who weighs 7 stone and someone who weighs 25 stone, and they're actually going to get the same dose. It's a standard dose, isn't it? Now, the dose actually in your blood is really variable according to how big you are. And in fact, we all metabolize or break down drugs in different ways. You know that from things like alcohol. Some of you will be very happily able to drink 4 or 5 glasses of wine and walk home, and someone else will have half a glass of wine and fall over. We all metabolize drugs in different ways. So there's a big variation in how much drug is in our body at any one time. And that's one reason why some people struggle with side effects of drugs and someone doesn't. So if you're on the first dose, the full dose, and it suits you, great. If actually on that dose it was really hard and you had to go down to a lower dose, that's the right dose for you. And remember that the effectiveness we talk about, whenever you look at those graphs or people talk about how long it might work for, or the percentage of people it works for, those are from trials where they included everyone in that readout, including those who had a reduced dose. They're not just talking about people at full dose, they're talking about everyone. So my short answer, not very good at short answers, is that the right dose for you is the one which you can tolerate. And if that happens to be less than the full dose, that's the right one. Because if you go up to something you can't tolerate and it causes kidney damage, liver damage, heart, lung damage, or just makes you feel awful, you're not really achieving very much.
And moving on and continuing in that theme, would it not be better to start everyone on a reduced dose of alectinib and get them used to that lower dose before titrating up?
It's also a really good question. I think the concern about that is that you don't want to come in a dose that's too low because there's a theoretical risk that it would maybe cause resistance. Now, it's never really been shown. And as I say, the reason we come in at the higher dose is because that's been shown to be the most effective dose that is tolerable. So the reason you want to come in at lower doses is that for some people, that reduced dose is going to be far too low. The amount of drug in the body is going to be too low. It's not going to be effective. And the concern is that might allow some cancer cells to escape, a little bit like taking a course of antibiotics that's not long enough and the bug never really goes. The worry is if you come in low, then you're creating a situation where there isn't really enough drug for anyone. So no, I would always come in at the recommended dose and see what happens. And it's not just size dependent. I'm thinking about a patient I look after who is on one of the ALK inhibitors. She is on a full dose and has done very well with it. She's in her 80s and is about a third of the size of me and has done brilliantly. And I can think of another gentleman recently who plays rugby. He's enormous. And actually the dose for him was half the full dose. For whatever reason, he was very sensitive to the side effects. So always start at the top dose, recommend dose. And if you need to, then you go down.
Okay, lovely. Thank you very much. So we've talked about reducing the dose. Here's a question for you. Obviously, we all know that 1,200 milligrams is the standard dose for alectinib. Could this be increased when there is progression?
I wouldn't do that. We haven't got any evidence behind that. When when cancer cells become resistant to a drug, it's usually not because there's just not enough drug there. It's usually because new groups of cells have developed, which have mutated again, and that new mutation makes them not sensitive to that drug anymore. Now, there are some situations where people have tried increasing doses of some drugs. I'm sure you have, of course, have heard of EGFR mutated lung cancer and osimertinib, and you may or may not know that when we didn't have any other drugs available, we sometimes increase the dose of that. Or in the older generation drugs, again, we doubled the dose because that's all we had. But those benefits are very short-lived. They usually come at quite considerable toxicity. But the real key in ALK is you've got another option. You've got other drugs to go to. And that's really, if you do need to be changing systemic treatments, you've got some very good questions coming up about other options, but when you have to change systemic treatments, in other words, you've got to change tablets. I would say, don't increase the dose. I don't think it's going to do very much. It might make people feel pretty rubbish. Instead, switch to the next drug advisedly and carefully.
Okay, lovely. And that does lead us on to the next question. It says, I'm taking alectinib and was told that there were various other TKIs, but I'm starting to realize that might not be the case. Would lawlessnib be the next step?
Yes, I think it probably would be within the confines of what's provided and funded through the NHS. And it's great that we do have that. That might sound like an odd thing to say, but when I was training as an oncologist, it would be the situation where we had, one chemotherapy, two chemotherapies, and other countries seem to have everything and NHS had nothing. That really isn't the case. We really have access to pretty much what we need, pretty much everything actually. So I think in a situation of something like alectinib wearing out, having had a good run, then I think it would be very reasonable to turn to lawlessnib. Different people would do different things, but I think that would be the most common standard switch. There is a question come up. I'm going to slightly jump ahead. That's okay, Deborah, just to say, yes. Someone else has asked about biopsying And what else might you do? And it feeds in really well to the question you just asked. So what you can do is you can retest the tumor. You can rebiopsy. And you're not looking to see whether the ALK is still there, because it will be. But what you're really looking for is you're looking at what new mutations have appeared. And how have those mutations allowed the cancer cell to become resistant to the drug? And is that why the drug has stopped working or become less effective? And there are some ALK inhibitors, for example, brigatinib, for example, or lorlatinib, even strangely enough, crizotinib, where you can pick one of those based on the new mutation known as a resistance mutation. So in a country where you have access to, or in a healthcare system where you have access to that kind of molecular testing, you could choose a slightly different drug to lorlatinib. You might choose brigatinib. You could conceivably choose crizotinib, but that'd be a bit unusual. So you could pick it that way. And when you look at what some of the kind of massive cancer centers in the States are doing, they're doing quite a lot of that because they have the resources to do that. Or I should point out, only a very small percentage of people in America have that. It's the super wealthy. It's not available to everyone. And you could do that. Whether that actually adds a great deal more than saying, well, I know lorlatinib is a good drug. I know lorlatinib covers lots and lots of those mutations. In fact, it pretty much covers all of those resistance mutations. I might as well just reach for that one. I'm not so sure. So if, in fact, your oncologist is saying, you've had a good one on alectinib, I'm going to reach for lorlatinib next. I'm not going to repeat your biopsy. I don't think that's bad medicine. I think that that's a very reasonable thing to do.
Okay, lovely. Thank you. Slightly different here. Are there any ways through diet to protect the liver and kidneys from the toxic effects of alectinib?
Yeah, I'm definitely not an expert on this. And I'm a great believer in asking my allied health professional colleagues. We work very closely with our dietitians, and I found them fantastic. So I would always defer to an expert like that. There's some really good dietitians around. I would always go for someone, if you can, who has got oncology experience. It is my understanding, with the caveat that I basically don't know what I'm talking about, but it is my understanding that there is no particular nutritional supplement or deficiency that's going to cause any particular damage to liver or kidneys. There are always some things. We always say if someone's got an irritation of liver, minimizing alcohol intake is one thing to do. But I think there's no particular foods that would protect you from side effects of alectinib, for example, or brigatinib in terms of effect on kidney or liver.
Okay, that's good to know. Thank you.
One thing I would add, however, is that you may be on other medicines that can interact and cause trouble. So, for example, statins, very commonly used for cholesterol, they can cause some effect on liver function. So if your liver tests are struggling a bit on a particular drug, you may want to just alert your oncology docs to the other medicines you're on and say, well, no, I'm on a statin. Might it be worth, for example, stopping that?
Okay, lovely, thank you. Another one here. I was told to take alectinib with a meal, but in the trials, the high-fat meals were used. Should I include fat in my meals? And if so, how much?
Yeah, I thought this was a really good question. Well done for knowing much more than I knew about it. So I actually had to really look at the trial because I suddenly realized I didn't know what I was talking about, which, as you can see, is a fairly common occurrence. If there is evidence with a lot of drugs that you can alter how much is absorbed by changing what's in your stomach, which sounds really weird, but it's all to do with often the acid environment and the amount of fat in the stomach and the bowel, and how much that allows a drug to get absorbed. And these are not the only drugs, lots of ones are like this. And the classic thing often is if you don't have enough acid in your stomach, it can create problems because the drug needs the acid to break it down to be absorbed. So often if you're on anti-acid medications, for example, it can cause trouble. It doesn't particularly with these. It's been shown in some studies that if you have a high-fat diet, you do increase the absorption of, for example, alectinib. So you could say, well, I'm going to have a high-fat diet, and that's going to increase my absorption. But we've got to go back to the trial that actually demonstrated alectinib worked. And in that trial, you took alectinib with food, not a high-fat diet. You took it with food, and double-check the protocol. So the benefit you're getting and the dose you're on alectinib is based on people who just had a normal diet with food. So you could have a high-fat diet, but you're going to be exposing yourself to more of the drug, perhaps. And if you were to expose yourself to more of the drug, you may find you have more side effects. I don't think we would say that you would have more benefit because we've got no evidence that increasing the dose helps. So I would say have it with food, have it with your normal food, but I would say outside of recommendations of your oncologist or outside of a particular study looking at it, I wouldn't go for a high-fat diet because I don't think that's going to make the drug more effective. All it's doing is increasing the amount you absorb, but the dose you're on is one which is aimed for people with a normal diet.
Lovely, thank you very much. Keeping with alectinib, and actually this is a question that comes up quite a lot actually. I'm on alectinib and the tumor in my lung has reduced in size. Would it now be appropriate to use radiation as well as alectinib to get rid of the cancer?
Yeah, short answer, we don't know. And it may be possible. It depends on a lot of things. It depends on how many metastases or how many areas of cancer there are. So people will often talk about oligometastatic disease. Oligo means not very many, some, and metastatic obviously means number of metastases or how many areas of cancer there are. There's good evidence in a number of different cancers and a number of different other types of lung cancer that if someone has oligometastatic disease and their disease is responding well to treatment, in other words, it's getting smaller or it's being controlled, that maybe you can target those comparatively small number of areas in such a way to try to control things for longer. We don't really know how many that means, but it's usually taken as 5 or less areas of metastases. The smaller number, the better. So following that argument, if, for example, there was one area in the lung on the right and one area in the lung on the left, for argument's sake, and they were both shrinking down nicely, you could argue, yes, we should try to zap those. We should try to give radiotherapy, maybe targeted radiotherapy, sometimes called stereotactic radiotherapy, to try to attack those. Now, we don't know whether that actually helps. We don't have any concrete evidence, to put it bluntly, it makes anyone live any longer. But there is quite good evidence in other types of lung cancer that it can control the disease for longer. Now, that might say, you might say, well, Tom, that's obvious. If I control the disease for longer, clearly someone's going to live longer, but we don't actually know that's the case. So that's why there are clinical trials going on. And one of the questions coming up asked about something called the HALT study, H-A-L-T, and that's been run by my colleague Fiona MacDonald at the Royal Marsden. She works within our team, next to hospital to us. And that study is looking at exactly this. It's to say, is there benefit in doing this? Because I think before anyone gets exposed to treatments like radiotherapy, you need to prove whether it's something to do or not. So the longer answer is maybe it is worth looking at radical treatments, radiotherapy, ablation, which is using heat, for example, to destroy bits of cancer. But I think at the moment that remains as part of a clinical trial. And it would always only ever be for a situation where there's a small number of areas, usually less than 5, and you can be confident that the current treatment is working.
Okay, excellent. Thank you very much. Okay. It's one of the questions you mentioned about biopsies, and it wouldn't always be the case, but someone's asked the question of what biopsies are available on the NHS.
Yeah, this is a really, really timely question. I'm trying to get my light a bit better. There we go, perfect. Maybe not. So there are two or three different types of biopsy. The first distinction between biopsies on the left is you have a tissue biopsy. So CT guided, ultrasound guided, getting a bit of tissue out with a needle, and then putting it in formaldehyde, fixing it and looking under the microscope. And then you can then go into the cells and get out the DNA and work out what's going on. The other type is called a liquid biopsy. Some people call it circulating tumor DNA, and that's a blood test. And it's looking for bits of DNA floating around your blood from the tumor. On the tissue biopsy, we all do tissue biopsies. The question really is, what do they do with that biopsy? Now, in the old days, by which I meant until pretty much the past few months, the way that ALK was found, ALK mutation was found, fusion was found, would be just through staining those cells with a special kind of stain, and then seeing how they look under the microscope, you could see whether there was evidence of an ALK fusion or not. And if you weren't sure if that was a bit of a kind of grey, wasn't quite a yes or a no, then you could send it off for some other fancy molecular testing, something called FISH, which is a way of looking under the microscope. More recently on those tissue biopsies, we've begun to sequence the DNA. And that's really important because the way that sequencing the DNA does is it's probably more sensitive. So it's going to miss fewer mutations, fewer ALK fusions. But also it will tell you about the details of the ALK fusion. And getting a little bit back to what I said before, if you know the details of the ALK fusion, actually what type it is, because lots of different types actually, then that might give you some information on the best type of drug for that particular tumor. May not be alectinib, it may be lawlessnib or the other way around. The UK is changing the way it's doing molecular testing and changing in a really good way. It's a rare bit of good news, which is that instead of having lots of local labs doing this in the local hospital around the corner in the dusty corridor, they're being sent to centralized labs where very high quality next generation sequencing is going on. In other words, looking at the DNA of the cancer cells. And it's great because the quality will be much better. And these are done geographically, roughly in the usual southwest, southeast, East Midlands, West Midlands, northeast, northwest Scotland, that kind of usual breakdown that we see. And it's called the National Genomics Programme, and each lab is called a National Genomics Hub. And so I think the quality of what we're going to get back is going to be really good, way better than it was a few years ago. And that will inform healthcare professionals as to where they are going with the ALK. And that is available already. But to be open with you, there is a variation in the quality of some of these in terms that some haven't got themselves up and running yet, whereas others have got themselves a bit more up and running. So if your local genomics hub isn't quite there yet, it will be soon, but maybe not quite yet. So that is all available in NHS. The liquid biopsies have not been fully approved or indeed approved at all. Now, your local hospital may have them. They may have them as part of a research study, what we have. They may have them as part of a compassionate access from the company make them. We also have that. And they may also have them as part of the hospital who's paying for it, which we also have actually, curiously. They're not routinely commissioned. And the names of these tests, one you may have heard of is called Foundation Medicine. Another one you may have heard of is called Guardant 360, same thing. And they're big commercial companies based in the States. You send your sample off in a blood test and you get the answer back a week to 2 weeks later. They're not necessarily better, but they're just another way of looking at it. And that is not routinely available, but maybe on an exceptional patient basis. For example, in our hospital, I'm allowed to do a Guardant test if I've tried to get a tissue biopsy and I haven't succeeded, or the quality of the tissue biopsy is so bad it involves bringing someone back for another biopsy. And then actually rather reasonably, my managers have said, well, that would seem to be more sensible, just do the blood test. So you will definitely have access to tissue. Your local genomics hub exists. There may be a variation in the quality of that. Your liquid biopsies do exist. They may or may not be available through your hospital, but we shouldn't see them as just being superior to a liquid tissue biopsy. They're just a slightly different way of looking at it.
Okay, lovely, thank you. The question here, what are the options after progression on lawlessness and maybe even then further progression after carboplatin pemetrexed?
Yeah, so this is, I guess, what we all think when we are trying to plan our treatments is what next. So I think it is likely in a situation when someone has been on a second generation TKI, so alectinib or brigatinib, and then they have moved on to lawlessnib, that when the lawlessnib wears off, probably what one's going to be looking at is moving on to chemotherapy. Now, I would always do a couple of things in that situation. If it was possible to rebiopsy, I would try to do that, accepting that it may not change what one does. You may get a result out saying, well, yeah, there's still an ALK fusion there, and we know that nothing's changed, and you've finished at lawlessnib. But I think I would try to do that if I could. I would certainly try to do that if it was easy and wasn't going to cause discomfort or upset as part of that process. I think if there was a clinical trial available looking at a new TKI, then that would be another reason to say, let's repeat the biopsy. It is likely, I think, however, after 2 lines of modern TKIs, we're probably going to be looking at moving on to chemotherapy. And what I try to say at the very beginning when I meet anyone where we're commencing an out-directed therapy is at some stage we'll move on to chemotherapy, and we should not see that as a failure. We should see that as an integral part of what we do. We know that patients without translocated lung cancer, chemotherapies, pemetrexed-based chemotherapy can be really, really effective. Not always. I'm not trying to pretend it's panacea, but it can be really effective and can go on for good periods of time. I think when one has gone through the chemotherapy side, I think the question again would be, can I rebiopsy? Can I rebiopsy, and does that tell me anything that I could maybe go back to a TKI? And that's a bit more of an unusual thing. And unfortunately, that's where the NHS funding does begin to be a bit more restrictive, because we often don't have access to go back to TKIs again, whereas in a lot of countries, particularly the US, they can kind of do what they want, which is not always a good thing. But I think I would think about rebiopsying, because I'd then be thinking what trials are available locally, regionally, nationally. After chemotherapy, the standard treatments would be seen as things like docetaxel chemotherapy, which is a hard treatment. Immunotherapy is in there as a potential treatment, but I would suggest that that's likely to be ineffective, in that immunotherapy alone is not an effective treatment, unfortunately, for lung cancer such as ALK or ROS1 and EGFR. So key would be rebiopsy, what trials are available, and then looking to chemotherapy, but not as an indication of failure, but as an indication of, well, this is the next step, and this is always something that we thought we'd have to do at some stage.
Okay, lovely. And moving on from that, people are always trying to be helpful when patients are in crisis, and people send in options for them all the time. Say, oh, I've read this, I've read that, that works. In your experience, after progression on lorlatinib and chemo, are there any proven, and I think that's the key word, isn't it? Are there any proven complementary or alternative treatments?
Not really is the answer, but that comes with a big caveat. And the first thing to say is I'm not going to be rude about other people's approaches, because I haven't got all the answers. We don't, as you guys know, have drugs that are going to get rid of metastatic out-translocated lung cancer. And I think it's, one should always be respectful towards other people's approaches. I like the term complementary, because that seems to me is working with conventional biomedical science. And there is very good evidence of benefit of a number of complementary therapies for certain things. There's very good evidence for the role of acupuncture in nausea, in pain, in anxiety, and that has been proven. They've done sham acupuncture where they put needles in the wrong place, and genuine acupuncture where they put needles in the right place, and there was a difference. I can't explain it. It doesn't make any sense to me, but it definitely works for things like nausea and pain. There's other therapies which clearly would make people feel better, such as reflexology. I mean, that was probably going to make you feel great, wasn't it? So I think in those kind of aspects, I think there are. I think then you move a little bit to where maybe some people would claim that their therapies are going to make cancer shrink down or make people live longer, and there really isn't any evidence about that. Now, an obvious argument against that is to say, well, no one's done the studies, because there's no money in acupuncture and there's no money in reflexology, and it's true. No one's going to do a study because studies cost billions to run, and there's no money in these products. So I think we have to be mindful of that. So I think if someone is looking at a complementary therapy and thinking it might make me feel a bit better, and I'm not being ripped off, I'm not being charged loads of money, and no one's making spurious claims, I'd say, why not? I would always just check it's not going to interact with the medicine you're on, particularly anything tablet-based, herbal remedies. There are a number of herbal remedies which can cause complete mayhem with drugs. St. John's wort being the famous one, grapefruit juice being another one. They really can cause all sorts of trouble. But I think if it's not going to interact with the drugs, then I would say, why not? I would always be really careful and highly skeptical of anyone who's promising a miracle cure and asking for money, because it probably isn't a miracle cure. And there's lots of unscrupulous people in the world who will promise you anything as long as you give them some money. And I think I'd always be very wary of those. I would strongly recommend the Macmillans, the Maggie centres of the world, the complementary therapy services working within hospitals. I thoroughly recommend working with allied health professionals, dietitians, physiotherapists, occupational therapists, clinical psychologists. I think all that is definitely complementary, and I think it's all part of holistic care.
Excellent, brilliant. Thank you very much. So, changing the subject slightly now onto scans. How often should routine CT and brain MRI scans be carried out, in your opinion?
Variable. In someone on stable on treatment, I tend to do CT scans every 4 months, roughly speaking, because I tend to give 2 months supply at a time, because that's easier for everyone. And so I do scans about every 4 months. If someone had new symptoms, new concerns, I would do that more frequently. MRI scans, I personally believe everyone with a diagnosis of ALK-translocated lung cancer should have an MRI scan. And if there's evidence of brain metastases, then that would be followed up in roughly the same frequency, although I tend to I tend to involve our neuro-oncology colleagues in following that up because they're much more expert than me, but they seem to scan also about every 3 to 6 months, depending where someone is. In the absence of any brain metastases, I don't think one needs to do it so frequently. I personally do an MRI scan of the brain about every 6 months in someone without brain metastases. I've got no hard evidence that that's beneficial, but I find it reassuring, and most of my patients find it reassuring.
Okay, that's lovely. Thank you. Okay. As well as regular CT scans of the thorax, should patients also have regular scans of the abdomen and pelvis?
Abdomen, yes, because you want to cover the liver and the adrenal glands, and that's in national guidelines of following up lung cancer. So definitely chest and abdomen. Pelvis, in the absence of any involvement of basically it's bone in the pelvis. I mean, there are lots of other things in the pelvis as well, but from a lung cancer point of view, the bit you're looking at really is the bone. In the absence of any known metastases in that area and absence of any symptoms, I don't routinely do a involvement of the pelvis. But if, for example, I know someone has a metastasis in the left hip bone, yes, I would include the pelvis.
Okay, lovely, thank you. All right. And it's there's another question in that area. Would scans of the abdomen and pelvis pick up other cancers?
I think it'd be highly unusual to find another cancer. I've been doing this for a long time. I can't think of a single case where that was to find a new cancer there, as in a new cancer, like a bowel cancer appearing. I think in the absence of symptoms, I don't think you need to be doing pelvic scanning if you've never had any evidence of cancer there before, but I would always do an abdominal scan. I think that's really key. The liver and adrenals are very important parts of staging of lung cancer, and that should be done every single time.
Okay, lovely, thank you. If my oncologist is not an ALK expert, how do I get a second opinion from an ALK expert? And after receiving the second opinion, do patients have the option of staying with their first oncologist or transferring to the second oncologist within the NHS?
Yeah, this is a good question. So it's something which oncologists have thought a lot about. I think that you don't have to be the world's greatest expert to treat ALK. There are some people who are, 2 or 3 people in the world who are true global experts, and they spend their time, as far as I can tell, not actually seeing any patients, but going around from transport to airport lounge talking. But I think there are these great experts. But I also think there are some really, really, really good oncologists who aren't necessarily the world's greatest expert in ALK, but will provide a brilliant care. So that's really key. And we have very good clinical guidelines. We have really good, clear clarity about what should be done. So I think if your oncologist isn't in a major teaching hospital and doesn't have, a clinic full of patients with ALK, they can still provide outstanding care, really can. And we're quite a close-knit community. Most people know each other, and lots of people phone each other up and say, well, what would you do? If someone felt that they didn't perhaps have the same confidence in that, yes, in the NHS, you can request a second opinion. You can technically go to any cancer centre and ask a second opinion. Now, they may or may not be able to provide that for you. The really big centres, like the Marsden, like, for example, the Christie perhaps, often are not able to provide second opinions because they just can't do it. They haven't got enough people. So that might be a bit of a a barrier, unfortunately, and it's just the nature of these centres. It's a bit like in paediatrics. Everyone's heard of Great Ormond Street, and Great Ormond Street can't provide a second opinion for the whole of the United Kingdom. It's just not big enough. I think but you can always ask for a second opinion. And if you go for a second opinion and find someone you like, and that doctor says, yeah, I'd like to take you on, absolutely, you can transfer. You know, this is absolutely within your ability, but your gift. That's how the NHS works. A patient looking after me could go and travel up to North London and be looked after by my friend Martin. Absolutely. So it does require the receiving hospital to say, yeah, that's fine, and may require referral from your GP, but usually it's much more straightforward than that. You just say, thank you very much for seeing Mr. Smith and taking over their care. I wish them the best. So yes, you can, but you may struggle if you're looking for the one or two really big national cancer centres. They may not be able to help you.
Lovely. Okay. Changing the subject now. What is local consolidation therapy, and what criteria is applied when considering it? And is there a different approach between brain and body?
So it's a little bit down to the oligomesetic thing I was talking about. So local consolidation therapy is trying to target a small number of areas with something to get better control in that one area. Usually radiotherapy, sometimes ablation, as I mentioned, like a needle with heat or microwave, sometimes surgery, but much less so. Not a huge amount of difference with the brain, except brain is nearly always just radiotherapy. You don't, as you might imagine, put microwave needles into people's brains. So that's radiotherapy. It's all to do with saying, if there's a small number of areas, can we zap those? That is really the case in brain disease. So we do know that with the advent of targeted radiotherapy, we can zap small areas in the brain. And that is something used much more. And that is local consolidative therapy.
Okay, lovely. Thank you. Right. This, again, but based on scanning here, all oncologists carry out regular scans of the body. They don't wait for symptoms. So why is it that some oncologists won't carry out brain scans until there are symptoms?
Yeah, it's not to do with, well, I think it's usually not to do with someone just not being bothered. There is a debate as to whether one should do it, because the advantage is you do it and you keep an eye on it, and if you see something, you can zap it, and that's the approach I take. If I know what's going on, then I can do something about it. The smaller the metastasis, the more you can do. But the other side is, if someone does have brain metastases, it's a devastating thing to find out. And if you do, it has big impacts on a number of things, including, for example, driving. If you know you've got a brain metastasis, that's your driving license gone for a year minimum. And given how the DVLA is currently not able to process anything because they're so inefficient, it may be more than that. So there's a school of thought to say, well, actually, if you've got no symptoms and you've got no evidence of brain metastases, why look for trouble? Because it would have quite a big impact on quality of life and lifestyle if you were to find out.
I'm going to be a bit contentious because I know this subject is close to many people's hearts within the group. So should that decision be made by the patient rather than the clinician?
I think everything should be made as a joint decision. I don't think, within the confines of appropriate medical practices. But I think if someone said to me, I really would like to have routine scanning done, I would say, yeah, absolutely. Now, it's depending on a little bit what your hospital can provide with. Lucky with Chelsea, we have good access to MRI and the rest of it. But I would find it quite difficult to say to someone, I'm not going to scan your head if you're worried.
Okay, lovely, thank you. Okay, right. Are there any clinical trials that are producing good results?
There are a few. So ensartinib is a drug which has come through reasonably recently. There are some new ALK inhibitors in very early phase. They're so early phase, they haven't got a name yet. Things like ABC 123, that kind of drug. Phase 1 studies of new drugs, particularly looking at resistant mutations of ALK, a little bit like lawlessness. Let's see what new mutations appear, and let's aim something particularly at those. So there are things coming through. I think it's fair to say that the first wave of trials of the new drugs, the brigatinibs, the lawlessness, have kind of come and arrived, and there's not a massive trial beyond that. So yes, some new drugs coming through in the relapse setting, but as an early phase at the moment.
Okay. All right, thank you. And very topical at the moment, especially with the numbers going up. Completely different subject, but would contracting COVID be more serious for lung cancer patients?
Lots of interesting evidence behind this. I was a great believer. I got everything about COVID wrong, by the way. I completely misjudged. I never thought it would come. I never thought it'd be this bad. So largely I got it all wrong. But one thing I did get right was I felt very strongly we should not stop any cancer treatments starting cancer treatments, because if you did that, well, you know what's going to happen. Whereas if you did get COVID, you're probably going to be okay. We know that if someone has a cancer diagnosis, on average, any cancer diagnosis, on average, the risk of getting complications of COVID is high. Now, that was based on pre-vaccine days. And of course, that's a huge range of patients, isn't it, with lung cancer diagnosis? It's a huge range of ages, genders, types of lung cancer, and how well someone is. As time's gone on, we've begun to understand a little bit more about what this all means. Number one, TKIs, out-directed therapy, does not increase the chances of complications of COVID, does not increase it. And in fact, the majority of patients with an out-translocated lung cancer are well. They are on their tablet, they are at home, they are being well. And so actually their relative additional risk of COVID is quite small. I think there is a slightly higher risk, but I think it is really quite small. The greatest risk, or the greatest predictor of risk of COVID, will be your age and your gender. And that will remain the case despite the cancer diagnosis. I think it's very important that you make sure that your relative or your friend's cancer diagnosis is known by the GP, so that you're first in the queue for vaccines. I would say to everyone, get a vaccine. There's absolutely no reason not to have that generally, but also no reason not to have it based on the cancer diagnosis or the treatment that you're on. So I think the additional risk is actually very small. And I think now that we have vaccines, I think the risk of getting COVID and getting life-threatening COVID is really small. And I don't think the cancer diagnosis or treatment adds very much to that.
Okay. And staying on the subject of vaccines, some people have been offered pneumo vaccine this year for the first time. Is it something that that patients should go ahead and get?
I think I would. Doctors always love vaccines, don't we? That's what we do. I think there's going to be, I think COVID's going to go up this winter. I don't agree, it's a bit more political. I don't agree with people not wearing masks on public transport. I don't know why we're not doing that. It's crazy. Particularly in London, it's not great. I think that there's going to be an increase in non-COVID viral infections, particularly flu. And I think we're already seeing it, aren't we? I mean, my kids are bringing out all sorts of stuff from school. I think if you can protect yourself, that would be a good thing. Vaccine's an easy way to do that. And we know that there's no issue with that and either chemo or TKI-directed therapies. So always have a check with your medical team before doing those bits and pieces. But as a rule, yes, I would get yourself pneumovax and flu vaccine and the rest of it.
Okay, lovely. Can I just swap and change around? I do apologise. We talked about the HALT study earlier on, but one of the things that I just think would be worth getting clarifying is will the NHS allow radiotherapy for limited progression in the body at the moment?
So I'm not a radiotherapist, so you get a better opinion from someone who is. And it's all about commissioning. But it is my understanding that it's in the NHS, stereotactic radiotherapy, so targeted radiotherapy to isolated areas of metastases which are not causing symptoms is not commissioned at present. That's my understanding. You can do palliative radiotherapy if something is growing, causing pain, you can. But I believe the stereotactic radiotherapy for oligometastatic disease is not yet commissioned.
That's lovely, thank you.
But if a radiotherapist thinks differently, then they know much more than I do.
Okay, all right. We are hoping to actually have Fiona take part in one of our Ask the Experts.
Well, I'd recommend her highly.
Yes. So brilliant. Thank you very much. Well, you've actually gone through all our list of questions. Incredible. So thank you very much indeed for doing that.
That's my great pleasure.
We have a few moments. I don't know whether it would be okay with you if there were any questions by any of the
sure.
delegates.
I will have to run at just before 7.
Yeah, that's okay.
Only because I might get in trouble because my wife's looking next door.
No, that's fair enough. And I'm not being, but I'm also waiting for my dinner as well. So yes, we will finish on time, I promise you. Is anyone got a burning question that they want to ask? It might only be the one that we get a chance to ask. I'm just throwing it out to the floor because people did ask. It looks like everyone's happy with the information they've got. There are a number of screens off at the moment, but I have got one from Caroline. So Caroline's put her hand up first. So Caroline, you need to come off mute.
I've just unmuted.
Lovely.
It's very interesting. Thank you very much. Just going back to the increased dosage of alectinib, the people who are on the worldwide site know that the Americans are very keen on the increased dose to up to 1,800 milligrams of alectinib per day, but you're saying that there's absolutely no evidence at all that, when you've got brain mets, you're saying there's no evidence at all that increased dose has any added effect.
Not quite. I guess what I meant was that I think if someone has brain progression, what I would be saying is let's do some radiotherapy to that, and their stereotactic radiotherapy is permitted. And I think I would be changing therapy. Trouble is that increasing that dose isn't licensed, and we are restricted in terms of what we'd be able to give in Europe and particularly in the UK because of that restriction. So America's tended to play around with doses much more, that they have much more freedom to do that. I think it would not be a standard approach I would take. I think if someone had control of thoracic disease, here downwards, but there was evidence of brain metastases getting worse, I would be speaking to Fiona about radiotherapy to that. And I'd be doing that. If I felt that generally we were losing control of the disease, I'd be switching systemic therapies. So yeah, there are some, tend to be quite small studies saying we increased the dose and out of our 15 patients, X number, it got smaller. But I don't think I would see that as standard therapy. I think most centres in the UK, unless they've got a way of funding treatment I don't, would struggle to get that funded.
Okay, thank you.
It's a great question, Caroline.
Thanks.
Okay, well, on that note, I think we will say thank you very much indeed to Dr. Newsom-Davis, and we'll call it a night. So we're slightly ahead. Your wife will be pleased. You're not late for dinner.
Well, thank you very much for inviting me. It's been very interesting reading your questions, and I hope it was helpful.
It was very helpful. So thank you very much indeed for joining us this evening. Really appreciate it.